So gastric esophageal reflux disease. Gastroesophageal reflux disease occurs when the contents from the stomach are being pushed back towards the esophagus, which causes irritation and burning pain in the stomach. We'd be studying about pathogenesis of GERD in this section. We'll be studying about the anti-reflux barriers that prevent the reflux to occur in the stomach. And we'll be studying about the mechanism of reflux, that how does the reflux really occur. And then the esophageal acid clearance that is important for reflux not to occur, and the gastric factors that help in producing a reflux in an individual. Anti-reflux barriers consist of four important barriers: the lower esophageal sphincter, the diaphragmatic crura, the phrenoesophageal ligament, and the angle of His. So if we study about the lower esophageal sphincter, this is located 3 to 4 centimeters in the distal of esophagus. It has an internal lower esophageal sphincter and an external lower esophageal sphincter. The pressure required to prevent a reflux from the stomach is around 5 to 10 millimeter of mercury. The diaphragmatic crura is a diaphragm. This is the costal part of the diaphragm which faces the ribs, and this is the crural part of the diaphragm. The crural part of the diaphragm helps in preventing reflux is by providing an extrinsic pressure to the internal lower esophageal sphincter, which helps in preventing the reflux. The pressure of diaphragmatic crura is also 5 to 10 millimeter. The diaphragmatic crura derives from the dorsal mesentery of the esophagus. Now, if we talk about the phrenoesophageal ligament, this blue structure over here is called as the phrenoesophageal ligament. What does it actually do? It helps in anchoring the lower esophageal sphincter and the angle of His. If you know, the stomach is present and the esophagus that enters the stomach, it enters in an oblique fashion, which provides a very sharp angle at the greater curvature of the stomach. This angle also helps in preventing reflux and is called as angle of His. So if we talk about the factors that really affect the lower esophageal sphincter pressure, we'd be talking about the hormones and peptides. If you see hormones and peptides, the gastrin, motilin, and substance P are helpful in increasing the lower esophageal sphincter pressure, whereas cholecystokinin, secretin, and somatostatin decreases the lower esophageal sphincter pressure. If we talk about the neural agents, alpha-adrenergic agonist and beta-adrenergic antagonist, they have a good effect on the lower esophageal sphincter, which increases the pressure, whereas alpha-adrenergic antagonist and beta-adrenergic agonist, which are completely opposite of these, they decreases the lower esophageal sphincter pressure. If we talk about the foods and nutrients, protein are good. They help in increasing the lower esophageal sphincter, whereas chocolate, fat, and peppermint, they decreases the lower esophageal sphincter. That's why they're harmful for the reflux. And the other factors are the antacids, baclofen, cisapride, histamine. They're all the medicines that help in increasing the lower esophageal sphincter pressure, whereas medicines such as barbiturates, calcium channel blockers, diazepam, dopamine, morphine, they have a negative effect. They decreases the lower esophageal sphincter pressure. So if we talk about the mechanism of reflux, there are 4 things that are very important that initiate a reflux. That is the transient lower esophageal sphincter relaxation, the swallow-induced lower esophageal sphincter relaxation, the complete absence of a lower esophageal sphincter pressure, and straining. So if we talk about the transient lower esophageal sphincter relaxation, this is completely independent of swallowing. It does not relate to swallowing. It occurs when the relaxation of the lower esophageal sphincter is longer than 10 seconds. It occurs in mostly all the individuals that have a reflux. If you see in this graph, the percentage of reflux disease is the highest for the transient lower esophageal sphincter relaxation. So most of the people, if they come to the OPD and they complain of reflex, it's mostly because of the transient lower esophageal sphincter relaxation. It relaxes for a longer period, and a reflex occurs. The second most important thing is the swallow-induced lower esophageal sphincter. This is associated with dysfunctional peristaltic movement. It is also associated with hiatal hernia. A reflex is normally not allowed because the diaphragmatic crura that I mentioned before does not relax. And the relaxation is usually very short, so it does not let the reflex come back. If we talk about absent basal lower esophageal sphincter pressure, is that the pressure is completely absent. So the lower esophageal sphincter is completely useless, and thus a reflex occurs. This usually happens in esophagitis. And if we talk about straining, straining is when the hypotensive lower esophageal sphincter is overcome by the increased intra-abdominal pressure. If the increased intra-abdominal pressure occurs, it causes the lower esophageal sphincter to open up and relax. It could happen while you're coughing or while you're bending or any sort of straining. But this usually does not occur normally because lower esophageal sphincter has a pressure of more than 10 millimeter of mercury, so it does not let the reflex to occur. Now, if we talk about hiatal hernia and acid pocket, how does it initiate a reflex? Hiatal hernia is when the upper part of the abdomen bulges through the diaphragm. You can see this is a normal stomach and the normal diaphragm. But in here, if we see, the upper part of the stomach is being bulges out through the diaphragm, and a hiatal hernia develops. A hiatal hernia increases the risk of erosive esophageal injury because it causes reflux, and it occurs in the hiatal hernia, and it involves the esophagus, and it causes very erosive, it damages the mucosal surface of the esophagus. Hiatal hernia has a lot of causes. Hiatal hernia could be because of inherited smooth muscle disorder. It could happen because of the reflex itself. It could happen in obese people, and heavy lifting can also cause hiatal hernia. It can cause the stomach to bulge out of the diaphragm. The other most important part of hiatal hernia is that it displaces the lower esophageal sphincter. For example, the lower esophageal sphincter is present right over here. It is with the diaphragmatic crura. But when a hiatal hernia occurs, it completely displaces the lower esophageal sphincter towards the chest, from the diaphragm towards the chest. And so the diaphragmatic crura is not there to help increase the pressure of the lower esophageal sphincter. So if we talk about the acid pocket is actually a zone which has a very high acidic property. The pH is extremely low at the acidic at the cardia, the stomach cardia. This is called as the acid pocket. This usually, whenever a food enters the esophagus, the food is being buffered by the food is being buffered, and it helps in acidifying the food contents. So the other gastric contents that occur over here, they're all being buffered. But there's a zone over here which remains unbuffered. The acidity of this zone is relatively very higher as compared to esophagus and the stomach. So this is usually called as the acid pocket. So in this acid pocket, whenever the acid has an increased acidic property, it refluxes back and causes reflux disease. If we talk about the acid clearance, there are the three factors that really help in clearing the esophagus from acid. That is the volume clearance, the salivary and the esophageal gland secretion, and the tissue resistance. These three things help the esophagus in clearing the acid out. The volume clearance is when the food is being brought into the esophagus. It helps, the volume clearance helps in moving forward the esophagus and clearing the esophagus of the acids and the food through into the stomach. it is used by the primary peristaltic movement, which is called as the swallowing. The swallowing initiates and it helps in clearing the esophagus of the food contents and the acid that is being produced in the esophagus. If we talk about the second most important part, it is the salivary secretions. The saliva, the normal saliva that is being produced is 1 to 2 liters. And this saliva, whenever there's an acid present in the esophagus, it increases the production of saliva. So the acid so in other words, if we talk about saliva production, the acid stimulation helps in increasing the saliva production and also increases the peristaltic activity. So now you'd be asking, why do we really need saliva? What does saliva do? The saliva has a pH of 6.4 to 7.8. So it naturally neutralizes the acid that is present in the esophagus. It neutralizes and dilutes the acid, and thus the esophagus is free of the acid present because of the reflux. Other than that, esophageal gland secretion, this also helps in producing a secretion which is bicarbonate rich. So this bicarbonate helps in neutralizing the acid, the hydrogen ions, and thus clearing the acid, clearing the esophagus from the acid. And if you talk about tissue resistance is divided into 3 parts. It has a pre-epithelial tissue resistance, epithelial, and a post-epithelial. Pre-epithelial consists of secreting glycoconjugates and prostaglandin E2, which helps in resisting the acid material. And the second is the epithelial. Epithelial has 2 components, which is a structural component and a functional component. The structural component is the cell membrane and the tight intraepithelial junctional complexes, which typically resists the acid. And the structural component is that the tight junctions, they literally do not let the hydrogen ions to enter the cells and the intracellular spaces. And if it does enter, it helps in removing out and excreting those hydrogen ions which are harmful for the cells. And the last, we're going to be studying about the post-epithelial component of the tissue resistance. In this, what happens is that whenever there's an increased exposure to acid, there's an increased blood flow of the esophagus to the mucosal layer. When there's an increased blood flow to the esophagus, it provides more oxygen, provides more nutrients, and provides more of the HCO3 bicarbonate ions, which ultimately helps in neutralizing the hydrogen ions and the carbon dioxide, which are the harmful effects for the esophagus. In the last, we're going to be studying about the gastric factors. The gastric factors depends on the gastric acid secretion, the duodenogastric reflux, and the delayed gastric emptying. So the acid production, which is produced in the stomach, and then the duodenogastric reflux and the gastric emptying. So if we talk about the gastric acid secretion, acid and pepsin are producing esophagitis are very harmful for the esophagus. This is the complication of a reflux. Acid does not really have a very harmful effect. It has a very minimal effect on the esophagus. But when acid is combined with even a smaller amount of pepsin, it has a very drastic injurious effect on the esophagus. So this acid and pepsin, when produced, causes a reflux and causes harmful, injurious effects on the mucosal of the esophagus. If we talk about the duodeноgastric reflux, the contents from the duodenum, if it reaches the esophagus, it has a very bad effect on the mucosal surface of the esophagus, especially if you talk about the conjugated bile acids. They have the greatest part in injuring the mucosal surface of the esophagus. And in the last, if we talk about the delayed gastric emptying. Delayed gastric emptying is when the contents of the stomach, they're present within the stomach and resides for a very long time. So when it resides in the stomach for a longer time, it causes more episodes of reflux to occur. As you can imagine, the food in the stomach is present for a longer time. It might reflux, it might regurgitate, and cause harmful effects to the esophageal mucosal layer. Thank you for watching sqadia.com, and please keep watching the other sections related to this topic.